So Stefan Wheat is the current Climate and Health Fellow at the University of Colorado. He is in Greenland right now, which is pretty awesome. So obviously he's unable to be in this conference room, but he was nice enough to record his presentation on indigenous populations, so we're all able to see it. I'm probably going to have to fiddle with this sound, so let's see. Where's the sound coming from? Projector?
Indigenous health in the United States. I'd like to start off with a disclaimer. I do not come from an Indigenous background. Much of what I have learned and what I plan to share with you here today is based on work that I've done with Indigenous leaders and Indigenous survey community. And why should we care? I think that's always a good place to start. I think most of us here today know why we should care about the impacts of climate change on health. In fact, the WHO has told us that climate change represents the greatest global public health threat of the 21st century. Why should we care about climate health as it applies specifically to Indigenous populations? Well, I think as emergency physicians, we're particularly adept at quickly recognizing patterns and incorporating them into our care. And from a public health point of view, we have to look for signals of harm to particular populations that portend harm to the greater population. And Indigenous populations offer us such insight. However, I want to stress that far from passively experiencing the adverse health effects of climate change, Indigenous peoples in the U.S. and abroad are paving the way for unique strategies to address the new challenges posed by climate change. So, how do we define a vulnerable population? Well, there are three traditionally considered factors when we think of what constitutes vulnerability. Those are sensitivity, adaptive capacity, and exposure. We think of exposure as the contact between a system and the climate. We think of sensitivity as the degree to which the system is affected by the exposure. And we think of adaptive capacity as the ability of an individual or community to develop resilience and adjust to climate risks. And we know that these three factors, exposure, sensitivity, and adaptive capacity, combine to inform vulnerability and ultimately health impacts on a population. We also know that there are many intersections between the social determinants of health and vulnerability. For Indigenous populations, perhaps the most significant social determinant of health is colonization. Displacement, forced labor, removal of children, relocation, ecological destruction, massacres, genocide, slavery, banning of Indigenous languages, regulation of marriage, assimilation and eradication of social, cultural, and spiritual practices have all resulted in reverberating mental and physical challenges. Let's briefly touch on Indigenous populations here in the U.S. There are approximately 574 federally recognized American Indian and Alaskan Native tribes, and approximately 5.7 million people identify as American Indian or Alaskan Native, which represents approximately 2% of the U.S. population. I think we should also care about this topic because these are our patients. The 2010 census revealed that 78% of American Indian and Alaskan Native people live outside of tribal statistical areas, and 60% of American Indian and Alaskan Natives live in metropolitan areas of the U.S. So let's briefly touch on health disparities in U.S. Indigenous populations. We know that these are significant. For example, American Indians have a 5-year lower life expectancy than the general U.S. population, and are 770% more likely to die from alcoholism, 420% more likely to die from diabetes, and 280% more likely to die in accidental death. And American Indian youth are twice as likely to commit suicide as their non-Indigenous counterparts. I'll briefly touch on the Indian Health Service because I'd be remiss if I didn't. And there are great triumphs that the Indian Health Service can point to. They've shown from 1972 to 1994 a significant drop in life expectancy, or a rise in life expectancy from 63.6 years to 72.5 years, and an improvement in the infant mortality rate where this declined from 25 per 1,000 live births in the period of 1972 to 1974 to 8.3 per 1,000 live births in the period between 2002 and 2004. But we also must recognize that the Indian Health Service also has a somewhat sordid past and has a history of forced sterilization in the 1960s and 1970s, and also more recently with COVID-19, Indian Health Service clinics have been understaffed and underfunded, and COVID-19 case incidents among U.S. indigenous people rose to 3.5 times that of among white persons, and indigenous people were nearly twice as likely to die from COVID-19 compared to non-Hispanic whites. So let's touch on enhanced sensitivity. When we think of the different exposure pathways to climate health impacts, indigenous populations are more sensitive across the board. For food systems, many indigenous communities rely on natural ecosystems for nutrition. This is particularly appreciable among Alaskan Native populations where access to grocery stores is limited, and many Native communities depend on salmon for food security. For water safety, a significant number of indigenous persons living on remote reservations lack indoor plumbing and rely on unregulated water supplies that are vulnerable to drought, heavy rainfall, and contamination. And from the standpoint of housing security, there are many examples of Alaskan Native villages who require relocation due to rising sea levels. And from the perspective of mental health, the 2016 Climate and Health Assessment identified numerous pathways that can lead to exacerbation of underlying psychiatric illness and development of new disorders among otherwise healthy people. Natural disasters and extreme weather contribute directly to stress that has significant psychological impacts. American Indian and Alaskan Native people are particularly hard hit because of how their health incorporates a planetary health perspective, such that harm to the ecosystems they coexist with may result in psychosocial distress. The American Southwest serves as an example of enhanced exposure and sensitivity among indigenous populations in the U.S. Most of the 21 Colorado Plateau tribes have experienced drought for more than a decade, and in the Southwest, drought is expected to increase in frequency and severity in the future. And on the Navajo reservation, 25 to 40% of residents haul water for household use at a cost 20 times more than non-Navajo water users in surrounding areas, while per capita income is less than half of the U.S. average. And this is a picture of several different parts of the Navajo Nation, mostly near Shiprock, New Mexico. We also know that there's a diminished capacity for adaptation. And, when we think of adaptation, and we have to think of what are the prerequisites for adaptation. And I think there are two key things that contribute here, and that's the authority to make decisions about access and use of natural resources, and flexibility to respond to impacts of climate change. And when it comes to authority, nearly every aspect of the tribe's economic development historically was controlled by federal agencies to some degree. And in many ways, federal and state policies for economic development and for resource management have inextricably tied tribes to unsustainable practices. And from the standpoint of flexibility, federal agencies and regulatory structures create barriers by restricting when and where indigenous peoples can hunt for wild foods, thereby limiting their flexibility. The Wind River Reservation serves as a valuable case study for this. And tribal autonomy was undermined by numerous factors. One factor was the concept of grouping. As of February 2017, tribal membership on the Wind River Reservation consisted of the Northern Arapaho tribe and Eastern Shoshone tribe, which were traditionally a warring people, and grouped these warring peoples together into one administrative unit, understandably hindering their adaptive capacity. And this is a picture of the Wind River Reservation. So let's dive into health impacts just a little bit more. So what are the health impacts of climate change on indigenous populations? They're the impacts we all hear about. The effects that we are told are coming if we don't make a change. but they are happening now for indigenous populations. Look at any of the major narratives of how climate change impacts the health of people, and you'll find indigenous people are at the forefront of these challenges. We talk about New York City and Florida and the coast of California being affected by sea level rise. Indigenous communities in the Southeast are already being displaced because of sea level rise. We talk about the degradation in air quality and exacerbation of chronic illnesses like COPD and asthma. Indigenous communities in the Southwest and elsewhere have higher rates of many of these diseases and experience air quality degradation more than the general public. We talk about food and waterborne illness becoming more common with climate change. Indigenous communities in Alaska already face food and water insecurity at a much higher rate for these diseases. And we talk about the mental and emotional impacts of climate change. Indigenous health is based on interconnected social and ecological systems that are being disrupted by a changing climate. Its impact threatens sites, practices, and relationships with cultural and spiritual and ceremonial importance that are foundational to indigenous peoples' cultural heritage, identities, and physical and mental health. Indeed, we can find the impacts of climate change on different indigenous peoples all across the country. But I think we also need to be mindful of the resilience that indigenous people have shown us. A growing body of research illustrates that indigenous people have significant resilience and are actively observing and adapting to change in a diversity of ways when it comes to climate change. Another valuable case study is the Swinomish in Washington State. The Swinomish have already launched projects aimed at helping the community adapt to shifting climate in the Pacific Northwest. To protect salmon runs, the tribe is working on the Skagit River to create better spawning beds and is planting trees to provide shade and reduce river temperatures. They are also using clam gardens to increase clam biodiversity, which reduces the incidence of foodborne disease in their populations. Elsewhere, the Karuk tribe of Northern California released its climate adaptation plan with a recommendation to return to prescribed burning, an old idea that might help to ease California's wildfire problems. The Tulalip tribe in Washington State are relocating beavers from urban areas back to traditional watersheds to help lower river temperatures and aid salmon populations. And the Confederated Salish and Kootenai tribes of Montana are gathering and planting seedlings of the whitebark pine that are more resistant to warming-related diseases such as blister rust. This is a photo of people of the Swinomish tribe in Washington State in their clam gardens. There's this other concept I want to briefly touch on, which is the fallacy of considering indigenous health from the standpoint of a traditional or Western or modern medicine perspective. The federal government is trying to assist indigenous efforts at adaptation, but often this top-down approach employs a Western framework that doesn't capture indigenous interests and or attention. Under the Climate Ready Tribes Initiative from the CDC, the Swinomish Indian tribal community located in Washington State, as I discussed before, has indigenized the CDC's Building Resilience Against Climate Effects, or BRACE framework, which is briefly depicted here on the left. For this indigenized BRACE framework, health is shaped by the many interrelated relationships among humans, non-human beings, and nature, and incorporates health indicators specific to indigenous populations. And for the Swinomish, indigenous health indicators include community connection, natural resource security, cultural use and practices, education, self-determination, and resilience. And these may be different from modern medicine's traditional conceptualization of what it means to define a health indicator. And it's important to note that these health indicators vary greatly from tribe to tribe. So what can we do? I think there are a few things that, we as community members, we as health providers, emergency physicians can do to learn more and be active with this community. We can learn about the tribes in our region. We can remember that health indicators vary from tribe to tribe and may be different from health indicators traditionally identified in modern medicine. We can respect traditional knowledge and practices and remember that the environment, culture, and people are intricately intertwined. And we can also consider working for a tribal health clinic because there are few substitutes for actually working with Indigenous people to learn from them and learn about how they are responding to the climate crisis. And finally, I'd like to end with this quote from the Fourth National Climate Assessment, which states that climate change threatens Indigenous peoples' livelihoods and economies, including agriculture, hunting, gathering, fishing, forestry, energy, recreation, and tourism enterprises. Indigenous peoples' economies rely on but face institutional barriers to their self-determined management of water, land, and other natural resources, and infrastructure that will be impacted increasingly by changes in climate. I'll leave you with that, and I thank you for paying attention.